I'd love to welcome and introduce our keynote speaker today, Dr. Mona Siddiqui. Dr. Siddiqui is the Chief Data Officer for the U.S. Department of Health and Human Services, where she's driving the strategy to connect the nation's healthcare data. As she leads the effort to build and implement the first HHS enterprise-wide data sharing platform and governance structure, she is also responsible for advancing the department's AI strategy. Please join me in welcoming Dr. Siddiqui.
Good morning, and thanks so much for having me. So as the first Chief Data Officer of HHS, I have the incredible privilege of working with some very mission-driven individuals and seeing the incredible power of connected data and how it improves the lives of all of us behind the scenes. I wanted to start off today by actually sharing some stories that illustrate the power of connected data. The HHS Empower program, how many of you know about that program? Okay, great. So let me tell you. So the HHS Empower program is a partnership between the Office of our sort of Preparedness and Response and the Center for Medicare and Medicaid Services. It provides dynamic data and mapping tools to help communities identify and protect the health of more than 4.1 Medicare beneficiaries who are electricity dependent and who live independently and rely on things like oxygen concentrators, home dialysis, wheelchairs, and who may be getting services like home health and at-home hospice. Since 2013, this program has empowered communities in all 50 states and 5 territories to strengthen emergency preparedness. It actually contains limited individual-level beneficiary information and healthcare provider information. It's a secure and restricted tool, but it can be officially requested by public health authorities to support life-saving assistance in the event of an incident, emergency, or disaster. So why does this matter? In August, during the California emergency power shutoff to minimize wildfire threats, this data helped local public health authorities to conduct immediate sort of response activities to locate electricity-dependent individuals and conduct life-saving outreach. More recently, during the Hurricane Dorian, health departments in Florida and North Carolina used this data to rapidly identify and reach out to electricity-dependent populations, and again, conducted life-saving outreach to these communities. Later this fall, we will be launching the inaugural Empower AI Google and Amazon Alexa virtual assistants. The historic 2017-2018 hurricanes and wildfires identified a critical need for first responders to be able to access this information. And we realized that the new virtual assistants could help empower data to the front lines and providing them with mission-critical information in fractions of a second. In another example, the newly launched Immunization Gateway is making a difference for families in tracking their healthcare needs. We all want the best for our families. For many people, this means driving across state borders to access better medical care. Since many public health immunization information systems are structured by jurisdiction, records inevitably contain enormous gaps. To bridge that gap, more robust data exchange between immunization systems is needed. To ensure that doctors are able to have this complete access to records, an Immunization Gateway Hub actually was launched earlier by HHS this year. This pilot took root in data sharing between the Delaware Department of Health and Social Services and in Philadelphia's Department of Public Health. Many Philadelphia residents are born in Delaware hospital systems. Some records of immunizations given at birth did not previously make it back to the doctors in Philadelphia. By exchanging the data via the Immunization Gateway Hub, over 1,000 immunization records became visible in just the first few weeks. Thus far, 20,000 immunization records have been made accessible by state and local health departments that were otherwise not known. For hepatitis B, the health departments were able to understand that their vaccination coverage rates were actually quite good and were able to divert resources to other areas. So while these two programs have been fairly recent, there are other long-standing programs at the department that show the power of connected data. For 20 years, how many of you know about PulseNet? Okay, so for 20 years, PulseNet is a national laboratory network that has triggered outbreak investigations by CDC far more quickly than before its inception. This program collects data for 9 bacteria. When just looking at the 3 most common foodborne pathogens, which include Salmonella, E. coli, and Listeria, this network prevents roughly 270,000 foodborne illnesses each year, and has actually resulted in the withdrawal of more than 1 billion pounds of food from the marketplace that's been contaminated. While it costs public health departments about $7 million to operate, it saves more than $500 million every year. By identifying problems in food production and distribution, PulseNet makes our food safer to eat and has led to changes in food production regulations, new federal recommendations, and has increased the speed and identification and recalls of tainted food. A final example that I'd like to share is the concept for mapping drug disposal sites on Google Maps, which came from a winning solution at the HHS Opioid Codeathon in 2017. Through the work of more than 250 coders who used 70 data sets, 3 winning solutions were developed. Team Visionist, which was one of the 3 winners, developed a prototype for mapping drug disposal sites that served as the genesis for the tool that was launched earlier this year on Google Maps. In scaling this solution, in collaboration with several states, CVS Health, and Walgreens, this pilot was launched as a first attempt at building a national set of drug disposal sites database. Initially, state governments in Alabama, Arizona, Colorado, Massachusetts, Michigan, Iowa, and Pennsylvania contributed data. It was an essential first step, but didn't include, obviously, all of the information. From the original 7 states, 10 additional states have recently joined, which include Connecticut, Georgia, Hawaii, New Hampshire, Nebraska, New York, Tennessee, Vermont, Wisconsin, and Washington. In total, greater than 7,000 locations have been mapped thus far on Google Maps. And again, I think show the power of connecting this data. The scope and scale of data of which HHS is the steward of is enormous. The efforts that are undertaken by frontline staff every day to ensure that the right information is getting connected to address a public health crisis or to try and anticipate an emerging public health threat are Herculean. I think it's not overstating it to say that in the examples I have shared and in countless others, connecting disparate information in these ways and deploying it through partnerships with both public and private entities is saving lives. This power and potential of data is only possible when data can be translated into actionable information. It's knowing the tremendous potential of connected data that has fueled our efforts at HHS to make the department a more interoperable healthcare organization. While I've highlighted some tremendous examples of how connected data can save lives, each of these individual programs has taken an enormous level of effort to build and to execute. As you know, HHS is a collection of many different agencies, including CMS, FDA, CDC, NIH, the Indian Health Service, the Administration for Children and Families, and many others. Imagine what's possible when information collected and stored in silos can be brought together and leveraged in near real time to track the progress of a particular condition or to track the emergence of the next public health crisis, or simply to understand how to better spend our limited resources, and to be able to have outcome metrics, to be able to test our underlying hypothesis about how we're running a particular program, and then to change it based on metrics that we're tracking. For the last 2 years, this is exactly the mission that we've been working towards. Knowing the power of open data and building on HHS's long-standing history of making data available for public use, we also began to see how is data getting used from one agency to another. The programs that HHS runs are not experienced by all of us as consumers in silos. So the approach to understanding the impact of those programs also needs to be integrated and embedded in evidence. It turns out, however, that programs that grew up in silos continue to operate largely in those silos. The data that's produced is also maintained within those silos. Mapping out how to change the way of this way of operating and how to create a foundation for an interoperable healthcare organization has required a holistic approach. I think as health systems and payers and other organizations are grappling with interoperability, which is a term we often use without really defining our set of expectations, I'd like to share with you a little bit of what we've done thus far at HHS and our approach to moving this work forward. So technology is not the solution to interoperability. The fundamental requirement is for business alignment, and I think we all know that. Whether from my experience as a primary care provider at one of the largest healthcare systems in the country to now leading this effort for HHS, the foundation has to be in first defining the problems or set of problems that we're trying to solve. Having completed an initial phase of our work that I shared actually here last year, where we spent significant time with our agency partners in understanding their priorities and their needs for their data portfolios, we were also able to understand the problems that they wanted to address. And in taking an enterprise-level approach and looking and working with agencies across the board, we were able to identify the common set of problems across those agencies. And that's been really critical. Because embedding the development of a data sharing enterprise in priority use cases that have been led not by me, but that have been defined by the people running some of the largest programs in this country has been a core value in this process for us. But beyond just defining the problems, this process is essential to building a stakeholder coalition because this work really requires, as we know, a long-term investment and a long-term organizational commitment. Business alignment and shifting how we think of data from a primary reporting and research tool to a strategic business asset, again, requires as a first step not a technological solution, but a change in organizational management and culture. How do we manage and govern our data, and how do we connect it to the business operations? Our approach has been to create a governance group comprised of stakeholders from across the department, but for the first time, reporting into the Chief Operating Officer for the department. Connecting the management of the data to the operations of the organization is another core principle for us in creating this organizational change. I would say perhaps one of the most important components in which we're investing significant resources is a data science training program for the department. Investing in our workforce and developing the internal capacity to use what we're building and to enable individuals to be change agents within their agencies is essential. Building these individuals, bringing these individuals that are currently scattered across the organizations to collaborate in more organic ways, in ways that are useful for their programs is essential. In a recent pilot program of this curriculum, for 30 spaces, we had more than 500 HHS employees apply, which again tells you the demand for this in all of our workforces. I think this is an important piece in building the workforce of the future and is a key component in allowing us to remain competitive, both internationally and nationally, and really, at the end of the day, is an economic imperative. The technology stack that we are building that enables sort of safe and secure data sharing, code sharing, data use agreement management, and workflow management is the final piece of what we're building. I would be the first to tell you that I don't know what the final product will look like. We have been taking a truly agile approach. It would actually be very easy to purchase, a multi-million-dollar solution and declare a quick win. But that solution likely would not be used by anyone and would certainly not lead to culture change in how data gets used or shared. It's actually much more difficult to get a stakeholder group to come together to develop and iterate incrementally on the right solution for them. We're taking the bet that the latter approach will lead to greater adoption, even if the development life cycle is longer, and are currently in the midst of standing up an MVP for the department. So creating an organization that is truly interoperable requires a change management approach of enormous scale. When I took this role, I thought I was taking a role of managing the data, but what I didn't realize, again, was that this was organizational change at one of the largest scales. It is easy to embrace technology as a solution and declare a quick win. But true interoperability, again, requires strategic alignment and taking an agile approach and investing in real workforce development, I believe, has a real potential to transform how we operate long-term. And it is a long-term investment, but one that I think can continue to yield returns, not only in program efficiency and effectiveness, but in saving lives and ultimately creating a healthier country. Thank you.